Good morning, everyone. Our today's seminar topic is on critical evaluation of methods in recording vertical jaw relations in complete denture. These are the contents. Coming to the introduction, the basic objectives of complete denture prosthodontics is the restoration of facial appearance and the restoration of function. One of the important factors for the same is recording accurate maxillomandibular relations. Coming to the maxillomandibular relations, they are of three types: the vertical relations, horizontal relations, and orientation relations. Coming to the vertical jaw relations, they are the ones that are established by the amount of separations of the two jaws in a vertical direction under specified conditions. It may be recorded as vertical jaw relations at rest and vertical jaw relations at occlusion. Vertical jaw relations at rest in denture construction is used as a guide to the lost vertical dimension at occlusion. Coming to the vertical dimension at rest is the mandibular position that is assumed when the head is in the upright position and muscles, that is the elevator and depressor muscles, are in the tonic equilibrium and the condyles are in the unstrained position. Coming to the vertical dimension of occlusion, the relationship of the mandible to the maxilla when the jaw is closed and the teeth are in contact. This position may or may not coincide with the centric occlusion. Coming to the freeway space or the interocclusal rest distance, it is calculated by subtracting vertical dimension at rest minus vertical dimension of occlusion. It's nothing but the distance between the occluding surfaces of the upper and the lower teeth when the mandible is in its physiologic rest position. So the significance of this physiologic rest position is the relaxation of masticatory apparatus, minimal activity in elevator and depressing muscles, and no strain on the TMJ capsules. Coming to the physiologic rest position, mandible is said to be in its physiologic rest position when the muscles of jaws are in the state of minimal tonic contraction. So the significance is that it's a bone-to-bone relation. It's constant throughout the life, and it is also used as a guide for the determination of vertical dimension of occlusion. So coming to the history, as early as 1771, Hunter wrote, when the motion is carried to its greatest extent in any direction, the muscles and the ligaments are strained and the persons made uneasy. In 1906, Walsh described it as the position of mandible, wherein all the muscle action is eliminated and the mandible is passively suspended. He reported that in this position, the opposing teeth do not contact. Human anatomists in the early 1900s believed in the theory that at the birth, the gum pads of the jaws were in contact, and with the eruption of the teeth and the growth of the alveolar processes, the jaws were forced apart, thus increasing the vertical dimension of face. Coming to the significance, again, it's a measurable distance. It's a repeatable reference with an acceptable range and a useful reference for determining the vertical dimension of occlusion, as we have already discussed. So coming to the classification of methods for recording the vertical jaw relations, they can be divided into mechanical methods and physiological methods according to Boucher. Under mechanical methods, we have pre-extraction records, profile radiographs, casts of the teeth in occlusion, facial measurements, ridge relation, and measurements of ridges. Under physiological methods, we have phonetics, aesthetics, swallowing threshold, tactile sense, and patient percept comfort. According to Swenson, we have ridge relation, measurement of former dentures, inter-arch space and physiologic rest position tests, pre-extraction records, Boo's bimeter, interpupillary distance, phonetics and aesthetics as guides, and swallowing threshold. So which are the pre-extraction records which are used for determining vertical relations? So coming to the profile photographs, so basically we take a lateral skull film before and after the extraction that gives us like 1:1 ratio of cranium to image radiograph in physiologic rest position, and measurements are then made which is used as a reference when patient becomes edentulous. And comparison is done of present radiographs with the previous one. So for the critical evaluation is not practical for routine use. Also, there will be exposure to radiations, and it is not applicable for the patients with any kind of congenital and acquired orofacial deformity. Coming to the profile photographs, they are made with the teeth in maximum occlusion, and then the measurements are made before and after the extraction. Critical evaluation, angulation will vary as per the patient's posture, and also accuracy caused due to enlargement that might cause the discrepancy. Coming to the facial measurements, according to Goodfriend, the distance between the pupil of the eye and the junction of the lips is equal to the distance between the subnasion to the nasion. So a new technique to determine vertical dimensions from anthropometric measurements of fingers was developed. The purpose of this study was to find the correlation between the vertical dimension of occlusion and the length of the fingers. A cross-sectional study was conducted on 400 dentate patients comprising of 200 males and 200 females. The measurement of vertical dimension of occlusion was done with the caliper. Then measurement of length of the index finger was done in case of males, and measurement of length of little finger in case of females. The best parameter to predict the vertical dimension of occlusion in case of males was found to be the index finger, whereas in case the best parameter to So the best parameter to predict the vertical dimension of occlusion in case of males was found to be the index finger, and in case of females it was found to be the little finger. Since the variations between the vertical dimension of occlusion and the finger lengths are within the range of 2 to 4 millimeters, so the vertical dimension of occlusion prediction, though this method is reliable and reproducible. Also, this method is simple, economic, and non-invasive, and hence it can be recommended for the everyday practice. Coming to the articulated casts before and after the extraction are compared. Critical evaluation, it cannot be used in long waiting periods, and also it is not useful in excessive bone loss. Coming to the measurements of former dentures, it's done with the help of Bowley's gauge. Like the borders and the occlusal surfaces of the teeth, this distance is measured with the Bowley's gauge. Critical evaluation is that it's applicable only if the old dentures are available, and also in case of residual rich resorption, there will be increase in interocclusal distance. Coming to the profile tracing, it's done with the lead wire adaptation. Wire is molded to contour the face starting from the eyebrows to just below the chin along the midline. Critical evaluation is that with the extraction, there can be change in the facial contour and vertical height. The decometer, it's an instrument that records both the vertical dimension of occlusion and the position of upper central incisors. It's an reputed accurate measuring device. Coming to Willys gauge, it is used for recording vertical height before extraction. The upper part of this gauge is placed in contact with the base of the nose, and the lower member is slid until it touches the lower border of the chin. Also, it is known as the eye, lip, nose, chin method. So critical evaluation, soft tissue landmarks are going to vary, and also it is very difficult to fix an exact point on the chin. Coming to the acrylic resin mask, it was given by Swenson. Acrylic resin mask is made before the extraction, and then the hydrocolloid impression of the patient's face is made, which is reinforced with the plaster before removed from the face. Then it is poured in the stone. 2 to 3 millimeters base plate wax is adapted, and then this wax mask is processed with a clear acrylic resin. The critical evaluation is that it's time consuming, precise procedure, less accurate, and also while taking impression, there might be displacement of the skin and there might be inaccuracy up to 2 millimeters. Coming to the post-extraction methods, first is the ridge relation, which was given by Victor Sears. Since the clinical crowns of the anterior and the posterior teeth have nearly the same length, their removal tends to leave the residual ridges nearly parallel to each other. Coming to the critical evaluation, it's difficult to visualize parallelism intraorally. Also, teeth are lost at different times, so by the time all the teeth are lost, residual ridges are no longer parallel. Also, width becomes discrepant. Coming to the distance from incisive papilla to the mandibular incisors, here the distance that is measured from incisive papilla to the mandibular incisors. So first we have the Niswonger's method, which was based on Niswonger's method that was based on the concept that mandible, it moves 3 millimeters upward from the rest position to the centric occlusal position. It's simple, accurate, and most commonly used. You ask the patient to sit straight with the head upright. Ala tragus line is parallel to the floor. Tip of the nose and the chin are marked with a point, and then ask the patient to swallow and relax. Measure the above 2 points, and this is the vertical dimension at rest. Then you have to place the rims in patient's mouth and ask the patient to bite in centric. This should be 2 to 3 millimeters less than the vertical dimension at rest, and this value is vertical dimension of occlusion. Coming to the PowerPoint or the bimeter or the Booz method, it was given by Ralph Booz. It registers the biting force at varying degrees of jaw separation. Attach the bimeter to mandibular base and a metal plate in the vault of maxillary record base. Gauge is going to indicate the pounds of pressure that is generated during the closure at different degrees of jaw separation. Vertical height is then adjusted by altering the occlusal rims till maximum biting force pressure is obtained. Coming to the critical evaluation, it's time consuming. Also, the vertical level of maximum closing power is indicated only on the effective parallelism of the ridges. Willys measurements is done by Willys gauge. At VDR, the distance A, that is from base of the nose to the nathyon, is equal to the distance between the pupils to the corner of the mouth. Again, coming to the critical evaluation, the soft tissue landmarks are debatable, and also Willys gauge is not as precise as the reputed tachometer. Coming to electromyography, it is based on the fact that minimal muscular activity occurs when the mandible is in its rest position. It produces more consistently reliable determination of vertical dimension at rest than the conventional methods. Electromyographic apparatus records and amplifies the electric response of a contracting muscle and displays it in a graphic form as a tracing. An electrode is used to pick up the signals on the skin surface. The whole muscle doesn't contract at once. Some muscle spindles contract in a coordinated way under the control of central nervous system, while the others are going to remain at rest, producing no electromyographic activity. An electrode may pick up a number of no electromyographic activity in its limited area, while in the other positions or the portions of muscle, the muscle spindles are contracting. This can produce a false negative response and impression, and under impression that muscle is at complete rest. Coming to the, so based on the fact that minimum muscular activity occurs when mandible is at rest position, it uses a special device that measures the tone of the masticatory muscles when tone is at its least contracting state. This means the muscles and jaws are in the rest position. Coming to the critical evaluation, it's not a practical method, too expensive, cumbersome, and it requires a trained personnel. Coming to phonetics, phonetic tests of vertical dimensions are going to include listening to the speech sound production and observing the relationship of teeth during the speech. Phonetics in recording the jaw relations, it is also called as the speaking method. Sibilant sounds like S and M are used. S is going to give the approximate closest speaking space, whereas M is going to give us the freeway space. Approximately 2 millimeters of the space must be there between the two occlusal rims. Coming to the critical evaluation, it serves only as a check to verify dimensions obtained via other methods. Coming to the Silverman's method or the Silverman's closest speaking space method, it was given by Mayer Silverman in 1952. Production of certain sounds like S, yes, brings anterior teeth very close together. So when correctly placed, the lower incisors are moved forward to a position nearly directly under the upper central incisors and almost touching them. It is useful as a pre-extraction method to determine and verify vertical dimension. As a pre-extraction method, patient is seated in the upright position and made to close in centric relation. Draw the centric occlusion line with a sharp pencil on a lower anterior tooth at the horizontal level of the incisal edge of the opposing anterior tooth, and this is called as the centric occlusion line. Now ask the patient to pronounce the words like yes, miss, buzz. Draw the line on the same lower anterior tooth at the horizontal level of the upper incisal edge, and it's called as closest speaking line. So now this distance between the centric occlusion line and the closest speaking line will give us the closest speaking space, which is usually 2 to 3 millimeters. So the difference between the closest speaking space and the freeway space is closest speaking space is measured during the phonation. The muscles involved is the phonetic action, and also patient cooperation is not required. Whereas in case of freeway space, it's measured during the rest. Muscles involved are also at rest, and the patient cooperation is needed. Coming to the swallowing threshold, it was given by Thomas in 1955. The position of mandible at the beginning of swallowing has been used as a guide for the determination of vertical dimension of occlusion. So in this, the technique is going to use the soft wax cones on the rims, and this induces the patient to salivate. And gradual swallowing is going to reduce the height of vertical dimension of occlusion. So coming to establishing of vertical dimension in edentulous subjects, at the jaw relation stage, basic method of recording vertical dimensions based on the rest position of the mandible by taking assistance of pre-extraction records if possible, verification of these measurements by facial measurements, speech test, tactile and neuromuscular perceptions and clinical judgment of the operator, patient acceptance and tolerance. At the trial stage, verify the vertical dimension of occlusion based on the facial appearance, interocclusal clearance, and speech tests. Justify the appropriate dimension based on patient's aesthetics and comfort. In case of increased vertical dimension, there will be discomfort to the patient. There will be loss of freeway space. Clicking sound will be there. Elongated appearance of the face, trauma, and pain under the basal slit areas of dentures, difficulty in swallowing. In case of decreased vertical dimension, there will be inefficient biting forces, cheek biting, facial distortion, angular cheilitis, and pain in temporomandibular joint. Coming to this article on re-establishment of vertical dimension of occlusion in denture wearing in 2 stages. Establishment of appropriate occlusal vertical dimension is a fundamental factor a new CD in harmony with patient's masticatory system. But long time use can cause the jaw displacement due to abrasion of artificial teeth and residual ridge resorption, causing the occlusal decrease in occlusal vertical dimension. So, one technique that is advocated for the re-establishment of the occlusal vertical dimension includes the use of an acrylic splint in an appropriate occlusal vertical dimension. This allows the assessing of patient's tolerance, aesthetics, and phonetics. Present case report describes a method of gradual re-establishment of occlusal vertical dimension using an acrylic splint on artificial teeth in an old complete denture patient. So this is the case report of 65-year-old patient who came to fabricate a new complete denture. So his complaint was poor aesthetics and ear pain. Examination revealed excessive wear of teeth with decreased occlusal vertical dimension, that is increased freeway space and pain in temporomandibular joint. Patient was instructed to reach a resting position after swallowing, and mean distance from the chin to the base of the nose was -3 millimeters was considered the occlusal vertical dimension. So using these measurements, aesthetic appraisal was done with occlusion of artificial teeth in position. Occlusal vertical final dimension was using phonetic method and quotation phonetics and the need of 14 millimeters for establishment of occlusal dimension was vertication was completed with expansions from three implanted dentures made alternate. Next, two occlusal records, one 10 millimeters for establishment of occlusal vertical dimensions in two stages. All the master casts were mounted in articulator for the manufacture of occlusal acrylic splints. First, the mandibular cast was performed to determine increase of 7 millimeters in occlusal vertical dimension, and autopolymerizing resin was used to make occlusal acrylic splint, and similarly for 14 millimeters maxillary splint. The maxillary splint was positioned on old denture fixed with the composite and to evaluate the patient's ability to tolerate 7 millimeters for a period of 30 days. After this period of adaptation, mandibular splint was then fixed to the old denture for a period of 30 days. Finally, after evaluating the adaptation, new set was installed. This process allowed for verification of patient's ability to tolerate re-establishment of the occlusal vertical dimension. To summarize, several methods have been described to obtain vertical dimension of the edentulous jaws, and no particular method has proved to be completely reliable by itself. A knowledge of most of them combined with the clinical judgment gives reasonable degree of accuracy and satisfaction. Dependence only on this method does not give satisfactory results. So this method requires to be checked and verified with other methods to obtain clinically satisfactory vertical dimension suitable to the patient. Coming to the conclusion, many methods of assessing and recording vertical jaw relations in edentulous patients have been presented and evaluated. Since there is no precise scientific method of determining the correct vertical relations, hence the registration of vertical relation depends upon the clinical experience and judgment of the dental surgeon himself. These are my references. Thank you.
This conference will now be recorded.